Children's mental health and public. I'm one of the tri-chairs. We have Rep. Exum, Senator Barr are also part of it. And today we're going to try to build a legislation. You're working on this for about a year. Year of work through figuring out the language and getting to the yeah. That's fucking hard. I appreciate it. Hey, how are you?
How are you? Oh, what a day, what a day.
Well, got this to happen here. I know Rep. Walker was very happy about it.
Yes, it should.
Nice event.
Yeah, Tammy's here. I just saw her. Yeah, she's here. Yeah. Yeah,
How are you doing?
good, good. I'm been interviewing for Susan's job, so figured.
Yeah.
Thank you.
Okay.
Thank you.
Big shoes to fill, but
I know. And we'll find out probably tomorrow. Yeah. Yeah, I'm hopeful. So.
hello. You're here. Long time coming.
So good to see you.
Too.
I just want to make sure. She's good. She's sit and relax. Okay. Yeah. You're good. Yeah. You're good. No, you're great. You're great.
I got ramble now. The shamble thing.
Yeah. No. But you just thank him. We've worked so hard. We're so proud of our work. We want to continue it, to that effect. And we thank the governor for the support and being here. Blah, blah, blah. Let me write all that down. Got it, Tammy.
You're so good.
You are.
That's what makes it extra special.
I tried to catch it. Oh, Lord.
Did we go right into a meeting?
Yes, yes.
Need a 5-minute transfer.
Maybe we.
Yeah,
have, like,
maybe.
a cookie break.
Yep.
People could.
Oh, good Lord. How you been doing? Yeah, the calendar still said the presser was at 1:30 in Old Crow. So, yeah, we ran over there like, oh my God, what's happening over there?
Right.
Yeah.
Very, very gently. She's gently. You look fabulous. long. What happened? Here I am and, okay, I have a.
Nice.
If he wants to come up here with us, that's fine. The bills are here at two. So I wait for the oven. There you are.
Put 'em- No. Thank you.
Uh-huh. Okay, great. Thank you for letting us know. All right. All right. Sounds great.
Get up and say, what's she saying? You get the history in the heart, don't worry. That's all you. Is this live? Okay. Just thank you, everyone. Hang on just one sec. The governor will be with us shortly, and then we're going to get into the program. I just want to welcome you all here. This is so exciting to see everyone, and especially to have the governor coming to sign this bill that you have all worked so hard to bring about. So hang in there. He'll be with us shortly.
Ready? All right. Good afternoon, everyone. I'm Claudio Gualtieri, Senior Policy Advisor for the Secretary of OPM and Tri-Chair of the Children's Behavioral Health Policy and Planning Committee. We affectionately refer to as TCB, or Taking Care of Business. Today, TCB is honored to welcome the governor and distinguished guests who worked so hard over the past year to develop a comprehensive bill for children's mental health that was just passed into law in the special session, and the governor is going to sign it into law this afternoon. Unfortunately, we don't talk enough about mental health in our country. It's often downplayed and kept in the shadows, and much of other illnesses like cancer or heart disease, we would talk about more openly. But virtually every family is also dealing with mental health issues. And there may be moments in their life when a loved one needs a little extra assistance and some mental health support. And we're here partly to say that's okay. There's no shame in that. They deserve our love. They deserve our support. And we love that the TCB is shining a light on that important need. I'm particularly excited about the bill because it does a couple of things. One, it's going to increase our referrals to community-based services that avoid emergency department visits and help expand our urgent crisis centers. I'm also excited about the pieces of this bill that address the affordability issues. For a lot of families, it's hard to pay for healthcare and pay for the mental health services that their children may need. One of the provisions in this bill will make it so that there's insurance coverage for applied behavioral analysis for autism services up until age 26. After the Affordable Care Act, a lot of individuals stay on their parents' insurance to 26. And this is an important change to make it from 21 to 26 so that that coverage can remain in place. There's so much more that I know my fellow tri-chairs will get into in talking about the specifics of the bill. But without further ado, I do want to recognize the support and leadership of Senator Looney, who, but for him and the speaker, we wouldn't have had this bill come back up in special session. So Senator Looney, I invite you to say a few words.
Thank you so much. This was, of course, a priority bill, a priority issue that the speaker and I did make a commitment to make sure that we took it up as part of the special session. The governor, of course, was supportive of that, and it was one that we felt was so urgent that we didn't want to wait until the regular session to come back with it again. The problem of children's mental health has been growing and become alarmingly evident since COVID began. Certainly, it pre-existed that, but we hear all the time that it is more urgent. We hear problems in schools all the time, and so many families, we find out, are unable to access any services beyond what might be available in their children's schools, because there are so many medical providers who are not taking Medicaid patients, not taking insurance in some cases at all. So there's a tremendous gap in coverage. We addressed that to some extent a couple of years ago, where we had a modest increase in the Medicaid payments to providers for professional services for children. But there's more that needs to be done, and that's why it was so important to do this bill. It was an important priority of the BPRC, the Black Puerto Rican Caucus, as well. And I'm pleased we were certainly able to get it across the finish line last week. And it will require Behavioral Health the Committee to conduct a study on existing children's behavioral health services. It will help us to get a better view about what is necessary. We know that places like the Child Study Center that previously were able to see patients fairly quickly once they had contacted that center, there are long waiting lists there and in other similar places. That's just a sign of the burgeoning problem that we face. I think the insurance coverage for autism services is also critically important, to extend that to 26 from 21. Also, there'll be a working group to review private health insurance coverage for children's treatment at urgent crisis centers. And that's something we need to be able to move to make sure that that access to those centers is fully covered by insurance, because they are so critical in intervention service for families who are just so worried about the crisis status of their children and don't know where to turn. That's going to be important. They'll report back in October on results and recommendations. So again, there'll be also a review of intensive in-home child and adolescent psychiatric services, requiring DSS to work with the Child Study Center on some of those issues. And it's so important. Again, this bill is important, although some might say that some of the parts of the bill are studies and examinations and assessments rather than actual policy initiatives, but they will actually prepare the way for those initiatives in the next session. So I'm here today to celebrate it, to thank the governor and all who worked on this bill. Thanks so much.
Our next speaker is what I like to refer to as the heart and soul of our TCB tri-chair, a person who championed House Bill 5001, the Children's Mental Health Bill, several years ago coming out of COVID. And I know the speaker's confidant when it comes to trying to address the children's behavioral health crisis. My state rep, Representative Tammy Exum.
Thank you so much. And I have to say, my heart is full as I stand here today. I reflect back I always think of the historical perspective. And, so many of you who are here have been stakeholders for a long time around children's behavioral health. But for the general public, so many people did learn of it during COVID. And it became something that was such an issue that we were hearing about it. There were children in the waiting rooms. We were reading articles about it. And I was personally experiencing it. And it was a great honor to be able to help champion the work that we did. And it was a big bill, but it was a bipartisan bill. There was not a single no vote. It spoke to the commitment that we realized that we had as a body and as a state. And I was so proud of the day that the governor signed that into law. But Section 70, which tells you how big this bill was, created Transforming Children's Behavioral Health Policy and Planning Committee. Oftentimes these committees are formed and they don't do much. They don't become something. But we decided, first of all, that was a really long name. So then we said, hey, this is going to be the TCB, the Taking Care of Business Committee. And some people might question and say, well, what exactly is going on? Children's behavioral health, we're not seeing a lot of changes. This is slow. It is slow. It is hard. It takes time to build a foundation and to build it up, which is why we need studies, which is why we need data. So when this committee came into being in 2023, We really looked at all the stakeholders that we could put together to bring together to comprehensively work on the issue we care most about, which is children's behavioral health, and looking at it completely from beginning to end. What are we doing well? What do we need to do more of? What do we need to do differently? What do we have for resources? And how serious are we? The urgent crisis centers, the UCCs had opened, they have been highly effective, but they're on their baby legs because they need funding. We're pushing for that funding. We want to keep that going. To operationalize TCB to do the work we're doing, we meet once a month. TCB, the membership, the working groups that we have like 8 working groups. They meet all the time. And it requires that kind of vigilance in order to be able to be successful. We can't do it as legislators with our part-time legislative roles that are full-time, but we can't do it. And all the other individuals with all of these different jobs can't do it full-time. But being able to fund and have the type of leadership that we have as far as an organizational structure that lets us do what we're doing today, it is changing children's lives. It is changing parents' lives. We're also going to make sure that we support our providers and to look comprehensively, and we don't leave anyone behind. So having the age increase on the autism spectrum to go to age 26, that's significant. And we're doing so many things that some of you've heard much of it mentioned today. I'm not going to go through it all, but I just want to thank sincerely all of you. I want to thank the governor for his continued support, Lieutenant Governor, the TCB chairs, the tri-chairs with me, my partners here. We couldn't do it alone, and with all of you. Thank you for caring and continuing to support these children. And we're going to continue to take care of business. I don't care how long it takes. Thank you.
Next, join me in welcoming the other tri-chair, our distinguished Kids Committee Chair, and someone who will talk through some more of the specifics of the bill, Senator Marr.
Well, thank you all. You know that being the 4th so far on the list, it makes a lot has already been said. And I am a firm believer in getting to the point of things and moving forward. So I'm just going to go back to a little bit about what the origins of this bill were supposed to do. They were to work on prevention, to work on early intervention, and to work on treatment, and to look at that within the framework of budgets and data. So when we look at the bill that we just did this past week in special session, and thank you so much, Governor, for calling the bill, and thank you, Senator Looney and Speaker Ritter, for making sure that we got this bill through, because it was a big disappointment to all of us last spring, but persistence works. And that is our theme here. We persist. So part of what we look at is the part of what the bill was as my co-chairs have said, a review of the crisis continuum of the urgent crisis centers. That's treatment. The increased insurance coverages for 21 to 26. That's also treatment. An SBHC, school-based health center study in collaboration with DPH and CASBHC. So many letters. And that's data. And then the ICAPS model in conjunction with Yale, and that's in-home child and adolescent psychiatric services. That's treatment and budgets, because if we do this when we do this quasi-experimental study, we can look to granting from federal funding to make sure that we are bringing this really effective program further out into Connecticut and covering more area. And then finally, and this is one of my favorite bits, is the providers of substance abuse services and also our behavioral health care advocate, who is new, Howard Savronsky, who was just named last year. The fact that he is joining us as the behavioral health care advocate and the substance abuse providers, that is both treatment and prevention. So we are following through on what we said we would do with this bill, and it does take time. Oh, dear God. We all know how much time it takes. The studies we've looked at, the reports we've looked at, the work that is being done, and I'm going to mention a few names, but please don't feel badly if I don't mention you. I mentioned Yale, there's DCF, there's DPH, there's SDE, all of the different providers at the state level, and then local providers on the ground. And you are showing up. Maybe you're not in the room every time, but you are showing up online. You are contributing to the work groups. And truly, while we are the tri-chairs, none of this would happen without all of you. So we thank you for being here.
And now we turn it to the part of the program where we have to talk to some of the leaders and the agencies that are going to have to implement some of this good work, because it's only as good. You can pass the bill and have the direction, but it's the execution that happens with our state agencies that's so important. So I'll turn first to Commissioner Hamilton, followed by Commissioner Jutani from DPH.
Good afternoon. It's always helpful to go after a few speakers have already done the overview, because I'm going to steal some things that folks said. I'm going to steal from Representative Exum, and my heart is full. I have been in this commissioner's seat for, I keep losing count, eight weeks, maybe a little over. And I am so thrilled about not only the continued partnership between the governor's office, and I thank him so much for his leadership on behavioral health issues, but the TCB, our provider communities, our parents, and all of you who have been active thought partners and advocates as we think through how do we improve quality, how do we improve access. We know the demand is there, and it's increasingly more demanding. How do we figure out, by studying, looking at data, the best way to make sure we're resourcing the right things, and that the outcomes and the services that kids and families need, that they are getting when they need it. So I look forward to the continued work together as we implement all of the components of this bill. As folks in the audience, I'm sure, are well aware, DCF is the lead state agency over children's behavioral health, but we can't and don't do this in a vacuum. Again, with the legislative leadership, sincerely appreciate that. Our sister agencies, and again, all of you, families and communities and providers, I am confident, not even optimistic, I'm confident that we will secure and obtain the goals that we have all collectively been working towards, not only with the TCB, but throughout the work that we do together in partnership. So again, I just want to thank everybody for being here, raising raising the bar, but raising awareness and continued awareness about the need and the commitment that we all have to helping to address that in the best and most efficient way possible. And thanks again to all of my colleagues, and to you, Governor. Thank you so much.
And next, Commissioner Jutani from DPH, who really helped us underscore that there was a vacuum, a gap in some of our data collection. So when we looked at school-based health centers, which are so critical, an access point for a lot of mental health for children, meeting them where they are in community, but realizing that the amount of data and reporting we get is only about a third, a small fraction of what's happening in our schools. So I commend her for coming up with a really thoughtful piece of this legislation that's going to allow us to be more targeted and informed when we're making policy decisions on scaling up and supporting our school-based health centers. So Commissioner Jutani, please.
Good afternoon, everybody. There's one place where we want our children going every day, and that is school. And they are a captive audience when they're in school. And we know for so many families that making appointments outside of school, when maybe you have 2 jobs, 2 working parents, siblings that are helping to care for a child, having to have that access point right in school to mental health services, medical services, dental services are so critical to ensuring that children can get vaccinations, preventative care, treatment, whatever it might be in real time. We as DPH fund 91 school-based health centers throughout the state of Connecticut. We've had over 32,000 children going to these clinics. We have over 139,000 visits over a calendar year. But the reality is that's a fraction of actually what's happening in the state of Connecticut. There are over 300 school-based health centers in Connecticut, but we as DPH can only provide data on the 91 that we fund. And so when TCB asked us What kind of coverage do we have of kids that can get care right in our schools? I can only give a third of the answer because I don't really know the full answer. And so the goal of the study that is within this bill is so important, which is to bring all the relevant members to the table. We are really looking forward to partnering with the Association of School-Based Health Centers and other clinics to figure out what exactly qualifies as a school-based health center. What kinds of services are these different centers in schools providing? How can we maximize access to mental health services for our children? And how can we work together so that we can figure out how to provide these data to the people who need it to make decisions about where we can best serve our children? So I really want to thank the tri-chairs of TCB. I want to thank Senator Looney and Speaker Ritter, and of course, Governor Lamont, for your support of this very important bill, because without the knowledge and data, we won't be able to figure out a path forward to really be able to know the data we need to figure out how to meet children right where they are in school every day. Thank you.
As we mentioned previously, one of the provisions of this bill expands out our membership so that we're taking into account people who provide substance use. Those providers are going to be built into our TCB moving forward. And we've also integrated the work of our brand new behavioral health advocate, Howard Savansky. So with this bill being signed into law, he not only is part of this press conference, but he's going to stay and do the work right after at the full meeting. So Howard.
You didn't tell me that part. Yeah, good afternoon, everybody. So I am Howard Sabronsky. I'm the new first state behavioral health advocate. And it's my honor to be here today to acknowledge another step forward that we in Connecticut are taking to advance the quality of care, access to behavioral health services for all of our children and families. It's safe to say that as far as behavioral health is concerned, Connecticut is no longer the land of steady habits. I've had the privilege of serving on the TCB since its inception, and thanks, as you've known, to this new legislation, I'll be able to continue serving in my new role as a state behavioral health advocate. The TCB is a proactive collective benefiting from strong leadership from our governor, our legislative leaders, our partners in local community, our vocally engaged community advocates, consumers, providers, thought leaders, government partners, who together are committed to finding innovative ways of improving the quality and delivery of behavioral health services to our children and families. The passage and now the signing of this bill proves that our voices were heard as we saw that our recommendations became legislation and law, which will now allow the full implementation of critical initiatives that will address individual need, system improvement, and the overall quality of care. It is our collective hope that what we learn from these various studies and reviews will inform and highlight a path forward, allowing us to further improve the vital behavioral health services that we offer. Connecticut is one of the most robust and well-supported behavioral health systems in the country, something we should all be very proud of. We equally are proud that we're not taking that for granted and continue to strive for ways to improve the quality, expand access, and give a voice to those who depend on these critical services. So thank you to the governor and to all those here.
To shed a little bit of light from the family perspective, we have someone with lived experience, Jimena Miller, who's the governor's appointee and the chair of the Autism Spectrum Disorder Advisory Council. One of the great things about this work at TCB is we were able to bring in and knot together the work that the Autism Council has been doing for several years and try to lift it up through TCB and make it pieces of legislation that's going to actually impact people and give better access to care. So with that, I'd want to turn to Jimena to talk about her personal experiences and some of the impact that this bill will have on her and her family.
Thanks very much, Claudia. Hi, good afternoon.
My name is Gymnast Miller, and I'm here today on behalf of the Autism Spectrum Disorder Advisory Council, ASDAC for short. I want to thank the legislators, specifically Senator Marr and Representative Exum, for working with ASDAC and to introduce the specific legislation in the Children's Behavioral Health Bill. Included in the bill has been mentioned, is the critical legislation increasing the coverage of behavior therapy services from age 21 to 26, while children are still covered on their parents' insurance plans. This legislation addresses a service gap, as young adults previously would lose coverage while still eligible for special ed services through the school year that they were going to turn 22 years old. In addition, it allows young adults with autism the ability to maintain necessary supports during a very critical transition period in their life, whether they're going to start looking for jobs or going to be going on to college. So on behalf of ASDAC, I want to thank Governor Lamont for recognizing the importance of increasing access to behavior therapy. This will improve outcomes for young adults with autism in Connecticut. Thank you so very much.
Now I'd like to introduce our distinguished Lieutenant Governor, Lieutenant Governor Weisswitz, to give a few words of remarks.
Thank you so much. It's great to be here to celebrate this bill signing. I know we have many in this room and many who are watching who are parents. And when our kids have a health crisis, it could be they break their arm, they get a severe cut, they have an infection. We know where to take them. We can take them to the hospital. We can take them to an urgent care. We could take them to a community health center. If we're parents and our child is having a behavioral or mental health emergency, that is much more difficult. Where do we go? Where do we take our child to address that sooner rather than later and not have them on a list where the problem is getting worse and there's nowhere to get the help and get the treatment? And that's why the governor and I are so very excited about this bill, because it starts the planning process to move us forward so that in the future, hopefully every school, every community will have a place where children can and young people can get the treatment that they need. Parents can have the peace of mind that that treatment will take place. They don't have to worry about paying for quality mental health care, and it will be able to be available and accessible right in the community. And so that's why I'm so proud to stand with all of these amazing agency, community, and legislative leaders to make this happen. And just a special shout out to Representative Tammy Exum, who literally tenaciously and fiercely has made this issue one that is mainstream and has strong bipartisan support. So thank you, Tammy Exum, and all the leaders who are here. We're so grateful.
Now for the most exciting part, because we're going to have the governor here make this bill official and put it into law. With that, I have the pleasure on behalf of the entire TCB, all the community partners and providers that came together to make this bill a reality, to welcome my boss and the distinguished governor from Connecticut, Governor Ned Lamont.
I'll give you a little idea, how this works. I heard from Cece and Tammy a lot about how important this was. And Marty said this is really a priority for our caucus. Matt was there, Tony was there. Tony, can we afford it? Yes, Governor, it's already in the budget. I heard from the advocates, I heard from Manisha, but I hear from a lot of people. And probably heard me say, I thought maybe a lot of this was somehow related to COVID and coming out of COVID. And I think I told you during those dire days. I used to listen sometimes to the 211 hotline, after the fact and just hear the desperation in kids' voices. But then I thought, okay, maybe this is related to COVID and we're slowly getting back to a new normal. And I went up to Enfield High School, it's a year or two later. And we had some ARPA money. So we told the kids, I think I've told a few of this, that, look, if you had $50,000, I know how your Board of Ed would like to spend that money. How would you like to do this? And big guy, looked like a tackle for the football team, said, Governor, I'll tell you what I want. I want more confidential counseling in Enfield High School. For me and for a lot of my friends who otherwise don't know where to turn. And Susan and I, that's the type of story that really makes us remember that this is not a short-term issue. This is not a COVID issue. This is a deep issue that is particularly acute in this day and age. I'm not sure that it's going away. And I'd say, thank God for each and every one of you and the practitioners. And tried to raise the Medicaid rates, tried to show a little bit of respect there, trying to keep this going through the ongoing advisory work. Howard, thank you. Keep an eye on these guys. Make sure they get the job done. And I was particularly thankful for that young man at Enfield High School who had the courage to stand in front of me and about 100 of his friends and say, this is the most important thing we could be doing. And that's why we're doing this today. Let's sign it, Susan.
Here you go.
Fabulous.
Ooh, this is the 49 cent.
What I think.
Yeah, you're welcome. So, you do all the work.
Great job, great job. Thank you. Thank you. Really appreciate it. Oh my gosh, I love it. Yeah. Oh, we didn't. Okay. Okay. You don't touch this. Okay. I think that's what.
I'm positive. It's not that heavy. Hey there. We actually have cookies to celebrate. Do we want to pass them around? Can we do that?
We absolutely can. Where is my team? Let's see. Okay. Thank you. Isabella, would you mind just getting some napkins though? So over at we'll get some napkins and we'll pass them around. It's a celebratory. Okay.
All right, so we just had a very exciting kickoff to this meeting, and I think we're all energized and ready to get to work. So we do have to review the October meeting minutes, and hopefully we can accept those. I know they were sent out in advance. So the first item is whether I'll have a motion to approve the meeting minutes from October as sent and submitted by our administrators. Do I have a motion? Thank you. Motion is moved and seconded. Any discussion, need for edits or changes to the meeting minutes as presented? Seeing none, so ordered, the meeting minutes are adopted. And now I'll turn it to Senator Mar. Do you want to talk through? I know we already sort of spoke about the special session overview, but if you want to recap and.
Nope, I think we all know what happened in special session now. So, but I did want to shout out, I'm not sure if Edith is here today, but I wanted to shout out Edith Boyle, who is one of our work group chairs. And I apologize right now, her agency has gone out of my brain, but I want to shout out the work that she has been doing, her agency has been doing in partnership with child mental health services. And I know that it is having a huge impact and they're having great outcomes. And I love the thinking out of the box work that she's been doing. So I apologize for not being ready, but I had to be ready for the press conference. So here we go. Erica, you want to take us away?
Yes, and I think we, as the chairs have said, I think we've done a pretty good job of the bill overview, so we can move forward. We do have some administrative updates to provide. Emily and I are going to tag team it as she is also coming down from she's getting better, but from a cold. So we'll tag team this together. But Emily, I'll give you the floor and then you can let me.
Okay. So our next meeting will be in 2 weeks. It will be coming up fast on December 3rd. Within this meeting, we're going to have a data spotlight on crisis services. So specifically UCC's mobile crisis, subacute stabilization data, and ED hospitalization data. We have also asked representatives from the 3 community-based UCCs to come along with United Way. For the CVW Summit, this was originally planned for last month in October and it had to be rescheduled. We are looking to postpone this to February. So this would be the morning of the February TCB meeting. So please be on the lookout for additional information regarding that. And then just a reminder coming up fast that the TCB will vote on legislative recommendations during the February TCB meeting. In the 2026 session will begin February 4th. So briefly, I'm just going to pass it to some of the work group chairs who are here to provide some updates. But in 2025, we have been meeting with work groups since April. Work groups including community voices, services, system infrastructure, prevention, and school-based. We have also enacted the Crisis Continuum Review, which was part of House Bill 8004 that passed last week. So I'll touch upon that as well. And I believe Jenny online, if you want to come off mute and provide some updates regarding the CVW.
Yes, thank you so much, Emily. Good afternoon, everyone. So I am a member of the CVW, and I have a couple of our members in the room and on Zoom as well. So thank you for that. The CVW priorities have been to evaluate what is happening in schools, what services and supports are provided for children and families across Connecticut from a youth and parent perspective. We also want to identify what resources are available for children and families after receiving behavioral health treatment or services. We're also evaluating family and youth support options and initiatives in Connecticut. We want to promote culturally competent care, peer-to-peer services, community health workers, and distribute their resources to the community. And as always, we want to engage children and their families in the TCB work. For transformational engagement with the community. As Emily stated, the overview of our meetings is we kicked off in September with an orientation at the CVW where the members who are represented by youth and young adults with lived expertise, as well as parents and caregivers with expertise of being a parent or caregiver of a child with a behavioral health need. We provided sort of an overview of the roles of the membership, the background of the TCB's work. And then in October, we had our summit, which was facilitated by Health Equity Solutions, which was a great day. And we really look forward to our continuing our work plan and to meeting with TCB leadership in February. Thank you.
And I do want to take a second because, the community voice work group is very critical, just like every other work group is very critical to this work. And I do want to take just a minute because we do have some of the members of the community voice work group who are parents and or young individuals. And as you all, as many of you say, we can't do this without them. We want to hear directly from them. So if they are here or online, if you wouldn't mind just introducing yourself, please.
Good afternoon. My name is Emona Patterson. I am a proud family champion peer intern for the Organization of Favor. I'm also a CVW member. I work very closely with the families, especially because my own experience led me to do that. It's an honor to be here today. It's my first time, and thank you.
Adriana.
Good afternoon, everyone. My name is Adriana Ramirez, and I am Executive Director of Connecticut Family Support Network. And we help support families raising children with disabilities and special health care needs across the lifespan. I am also a family member, so this particular initiative really comes from the supportive that we see that parents and families need throughout the state, both in English language and Spanish language and other languages also. So I'm really excited about this initiative and the work and the passion that the TCB team really shows in all the meetings. It's really to be part of a committee that the passion and the questions and the interest is truly there. And it's very inviting to those that have lived experience, whether parents, caregivers, siblings, or individuals receiving those services, really demonstrates the, I think, actionable things that are going to be coming from this planning committee. Thank you.
And I believe there is a parent online, Lena.
Hi, good afternoon, everyone. My name is Lena Esposito. Then I'm coming from Connecticut Family Support Network as Adriana. And for me, it's definitely, a pleasure to be here. It's the first time that we are here. The transformative behavior is very important because I also have a parent that it has a child with mental health behaviors, and I know what is the challenges, the difficulties, and everything that we pass through having a child with disabilities. Then thank you so much to have us the opportunity to be here and be part of this team. And thank you, the TCB, for the opportunity, and they're so helpful and motivated. And then we're looking forward to work very hard to help the community. Thank you.
Thank you. And there are other members, I don't think they're here today, but we will make sure to also send you all the sort of a distribution list that identifies who they are. But this is a really critical piece of work, and I'm really excited to work with them. And go ahead.
I forgot to add, everybody that knows me here, they know I like to speak. And I don't know if this is the time that I can share something with you all. This is my first time actually in person. I'm always in Zoom. But I just wanted to share how my lived experience has shown me that while policies and technical expertise are essential, they don't always capture the human reality behind the system. They are meant to improve. Policy can outline what should happen, but they can always account for the barriers families face when trying to navigate those systems, such as language differences, cultural mistrust, and transportation issues or emotional burnout. For example, in my own advocacy and peer support, I have seen family who technically qualify for services but still fall through the cracks because no one took the time to understand their story or build trust. My experience also always allows me to bridge the gap, translating the technical into practical, helping professionals understand what family truly needs beyond what is written in a manual or policy. In other words, I highlight the human layer that data, policies, and expertise can measure. Empathy, relationship building, and live insight. These are what really truly bring policy to life and make technical solutions effective and sustainable. Thank you.
Thank you so much. Thank you. Emily?
Okay, so I will pass it to Jan. If you want to provide just some brief services work group updates. I know Edith is out of office right now.
Thank you. And thank you to the prior speaker. That was so lovely and so well put. And trust and relationships and empathy are so foundational. I also appreciated seeing I've been to many ribbon cuttings, but I don't think a governor's signing. So it was a fun thing to watch. I appreciate that. And I'd also want to thank Toe again because keeping just executive function, just a brain, you're our brain. So thank you for being my brain a lot of the time. So in the services work group, we identified several priorities. So the priorities identified include peer-to-peer support and 211 services. We will monitor the TCB recommendations related to the crisis continuum, UCCs, and ICAPs. And our work group additionally receives updates on the survey that we put out together. And that was really a core activity of the work group till now, was really putting it together a survey that allows us to better capture what is out there, what is available, what are clinics doing. And it's a really complicated data to acquire, and we thank Innovations for partnering with us in getting that information. As Claudia always says, data-driven, as all of you are saying, data-driven, as AC too. And we also had a couple of, as the services array work group, we had several presentations that look at essentially the array of services, and there's some that we still need to continue with. But for example, substance use, which we haven't talked, I think, all too much about, was a presentation that we had to better understand. We've of course talked about ICAS before. I mentioned peer-to-peer. We will meet in December, and CHDI will present findings of their peer-to-peer study, as well as have UConn Innovations give us update on the survey, as I just said. So those are the activities going forward. What I see as a big part of the services work group and our goal as a whole is to uncover the nooks and crannies of services and what's available and what's not available. I think a challenge sometimes is he who is not here, please step forward, and that makes it challenging. I think the other area that we probably need to focus in on, although there's separate activities for this, is just the developmental disabilities, intellectual disability, autism, and those areas as well. Thank you for your time.
Thank you. I will pass it to Alice and Jason.
I'll take the first part, Jay, and you can do the second part. Hi, we're co-chairs of the infrastructure group, which basically is looking at lots of different areas, financing, governance, and data related to the infrastructure for children's behavioral health. And we've used the last 6 months or a year, I don't know, it's been a long time, but about 6 months reviewing what the state of Connecticut and resources they have already related to the system of care that we launched here in Connecticut in 1998. And over the last few months have been really impressed with the large amount of steps, so to speak, that we've taken to be able to put in or implement a system of care, which is kind of a lingo for really one door and with care management entities and mobile crisis really being the partnership. Many states, I think quite a few, probably 30 or so, have implemented this model, and Connecticut is seen as the lead in the country and has been the lead in the country for this model. But we kind of have been on a delay a little bit, I think, and so we're having some really good conversations around what we would need to do to be able to step it up and catch up. Someone said, was it you, Andrea? I can't remember. Yesterday, we had a presentation in our meeting from the New Jersey System of Care, which was really kind of impressive. They've been doing it for 25 years, and they are very, they have had an enormous amount of wins. We learned that they have 60,000 kids in care coordination in New Jersey right now. Now they have more kids than we do, right? I don't know how many we have in Connecticut, but and so that was pretty impressive. Their budget is $265 million, which compared to ours isn't really that much more, right? But it's larger than the child welfare budget. And one of the things that they do is when a child is put into foster care, they put mobile crisis in with them for 6 weeks to follow them and make sure the child is steady and sturdy in the housing. And they've had a very decreased amount of transitions from group home to group, from foster home to foster home, which being a foster parent myself, I think is extraordinary. And they are seeing a decrease in adult mental health issues and a reduction in incarceration. So that's New Jersey, and there are many, many states that are doing it. I heard Jeff Vanderpool told me that New York is putting $1 billion into their system of care this week, or I don't. That's a lot of money, but well, Jeannie would know because she used to work there. They're $1 billion, but we're there almost. I'd say we were talking 1,000 steps. Andrea said it was maybe we're 500 steps in. So we just have to really keep our eye on this and really work together. We had a very great panel this morning on care coordination and hearing from the community health worker groups, as well as folks at Carillon and Yale New Haven Health System and community health workers, and Clifford Beers, which has been running a care management model now for the last 5 years. And just great discussion from the legislators there, and really looking forward to seeing what we could do together to be able to do this. And so the infrastructure group is really focused on that, and the other part of our work, if you want to fill in, Jason. Thank you.
Sure. So as Alice said, the last 6 months or so have really been focused on the system of care. I think just as a teaser for what we're looking at going forward is going to be around the data and, what data do we have about the behavioral health system in Connecticut? What don't we have? What do we want? And now that we have that report from the Innovations Institute, which looked at all of the data sources and gave some recommendations for next steps, we're going to take that and then figure out where do we go as a state with data.
So unfortunately, the prevention and school-based co-chairs are unable to be here today. So we are actually going to skip over these and have them provide updates at the November meeting. December meeting. But I will pass it to the behavioral health advocate, Howard, just to provide an update on the crisis continuum and UCC marketing and utilization work we have been working on.
Yeah, hi, thank you. So I think we recognize that for the UCC to continue and to grow, two major elements have to be addressed. One is the financial structure, and there's a group through the crisis continuum that's working closely with DSS and DCF to try to address the establishment of rates, and that's going very nicely. And I was asked to head up a group to look at the other element, which has to do with utilization, because you can't have one without the other. And so we pulled together a group of all of the UCC members, providers, along with our partners at DCF, Dr. Gregory and Stephanie Bozak. And we actually met in person. And I would have put a plug in for personal in-person meetings after spending all these years on Zoom. We got a lot of work done, and we had a really robust, honest conversation about how do we address and increase utilization of the UCCs. We started with a very narrow conversation around marketing, looking at flyers and how do we reach the public. But that expanded to looking at specific targeted audiences, such as primary care providers and schools, faith-based organizations. How do we get to the parents, to those that are most likely to use these important critical services? And how do we develop a marketing strategy that specifically targets them rather than a sort of a broad approach that will, sort of a generic sort of, marketing service? We also started talking about the use of community dialogue and whether or not it makes sense to partner with our local legislators and to engage and partner in creating community conversations around broad topics around behavioral health, which would then incorporate conversations around suicide prevention, around UCCs and the like, which will serve a number of purposes of getting our word out, engaging with the community, and also bringing along some of our legislative partners in the process. During the course of the conversation, we also began to realize that there's our systems issues as well, in addition to marketing needs, and that the UCCs don't operate in a silo, that they operate within this crisis continuum, and that they're dependent in many ways on the work of United Way, of our 211 systems, and of our mobile crisis systems. So the next meeting that is scheduled sometime soon, I rely on Emily to keep us on track. You want to?
I think it's going to be December 3rd.
Thank you. We've invited United Way to participate in this conversation to talk about how we collectively can come together and begin to look at how do we tweak the system. Instead of being, sort of accepting the way things are, now that we've had, at least a year or so of the UCCs operating, how do we now take that knowledge and bring that forward to the United Way and see how do we improve the way in which we communicate, dispatching mobile crisis, and connecting with our UCC resources. So stay tuned. Thank you.
Excuse me, Erica, can I just say one thing? I hope everybody has seen the wonderful commercials on the TV for the UCC centers. They are fantastic, and I thank you for that. I'm assuming that's what you were talking about, but it would be nice if maybe we showed some of them at the next meeting, because I really, it lets you know that your voices are going out there in the community, and that is, I've seen them in the morning at 7, and I've seen them at night at 11, so you cover both ends, so thank you.
Thank you. So we will now go on to our next agenda item, which is the Rural Health Transformation Grant Program.
Erica, if I could take a moment of personal privilege while our guests are setting themselves up. I want to thank this committee because we had very short order, and I know Joel and Nick will talk about how intense the process was to come up with, in a short 6-week period with ever-changing guidelines, a federal grant application for $1 billion. So it's hard to spend $1 billion thoughtfully in a competitive process, and to do it in 6 weeks, a testament to Nick in particular on my team and Joel from the DSS team. But I also want to thank this committee because we had very short time to get letters of support. And part of what we get graded on from the federal government is the broad-based support that we can show in community. And within a matter of 2 days, we went from my tri-chairs saying, yes, let's do it. Let's put in a letter of endorsement on behalf of TCB. We wrote a very thoughtful letter. And then we had every work group member sign it. So we got like 12 people to sign that in a matter of a couple hours and had a really good letter. So I can't thank you enough. That's sort of like lifting up each other's work and making it real and trying to get some money. So I just wanted to thank the TCB for that. And with that, I'll introduce Nick Turcott, a research analyst at the OPM team. He took on yeoman's work in trying to project manage and quarterback this task. And then Deputy Policy Director of DSS, Joel Norwood, who is also a Medicaid attorney, so came in very handy for helping us think through what was permissible, how do we be smart about what we write into our grant. And I know that it was a good collaborative effort across all of our state agencies and our community partners. So with that, I'll turn it over to you guys to present.
Thank you so much, Claudio, and thank you to everyone for having us here today. My name is Nick Turcott. As Claudio mentioned, I'm a research analyst within the Health and Human Services Policy and Planning Division at OPM. And I'll start off by saying the Rural Health Transformation Program did represent the product of a lot of late nights and weekends and just a huge interagency collaborative effort, but it was also a passion project, not the least for me, but for Joel and for many of our interagency colleagues that helped chip in and make this possible. So for today, we're planning to walk through what the Rural Health Transformation Program is, and then our process for preparing the application, and then give an overview of our initiatives. But with that, I'll pass it over to my colleague Joel Norwood, the Deputy Policy Advisor from the Department of Social Services.
Great. Well, good afternoon, and thank you for having us here today to give an overview of this massive project. I also want to specifically call out my colleague, Dr. Mehul Dalal, the Chief Policy Advisor. So the two of us have been the leads on this project at DSS, as well as at work from many agencies. So just a quick overview. The Rural Health Transformation Program is part of Federal Public Law 119-21, also known as HR 1, also known as One Big Beautiful Bill Act. Call it what you will. It is part of that massive bill. It came in at the very last minute of those negotiations. Some of you may have seen. So it was part of a compromise requested by Senator Lisa Murkowski of Alaska, concerned about the impact of Medicaid reductions on rural areas. And so that was the genesis of it in the federal legislation. What actually passed was much broader than the initial reason for it. And it's $50 billion over 5 years, half of it approved equally among all approved states. So if all 50 states are approved, then that will mean $100 million a year for 5 years for Connecticut from that half. And then the other half is distributed based on a variety of factors. So some of them, there was nothing that we could do in our application about the fact that Connecticut is a small, relatively non-rural state, obviously. But then there were other pieces where the federal government was prioritizing certain initiatives. And so some of those will factor into the total grant award. As Claudio and Nick mentioned, this was an extremely fast process. Federal government issued the notice on September 15th, and the deadline was November 5th. And there were many, many criteria. It was a very complicated application. We submitted the application on November 4th, and by law, within HR 1, CMS is required to issue decisions by the end of the calendar year. And then from there, it will continue moving very quickly. Next slide, please. So the funding notice and many pages of frequently asked questions and upcoming guidance that hasn't yet been issued. It's a very complicated program. It's obviously designed to focus on people living in rural areas and focused on transformation. That's in the program itself. So the specific rules, I'll just highlight one or two. One of them is that it can't duplicate services that are otherwise payable by insurance or Medicaid or any other source. It's supposed to be for transformation, for new things. And then there are other specific things that were not allowed, such as student loan repayment, transportation, broadband expansion. But what it can focus on is addressing health in rural areas in several ways. And we can get to that a little bit, but next slide, please. So as was mentioned before, we really looked among the state agency group and among a variety of stakeholders, as big picture as we could think about all the different ways of improving health for people living in rural areas. And the list of agencies that were particularly involved are listed here on the slide. And reflecting the complexity, our application includes 31 distinct sub-projects within our grant application. We'll see what CMS does. That review hasn't completed yet. If anyone's curious about the details, the link to the DSS website where all of our materials, the key materials are posted, is right there. So feel free to read that if you're curious. There's a lot of detail in there, both the details of the projects and the proposed budget. I will say the budget, CMS instructed every state to put in a placeholder of $200 million a year. We know that we'll get something less than that. We don't know exactly how much, so take that level of detail with a grain of salt. And then finally, we really wanted to hear from a variety of stakeholders. So we had a written comment period. We received over 250 written comments, and we had a number of informal meetings with a variety of stakeholders, some of which are listed here. And then we had 3 listening sessions, 2 of them in person, one in the northeast corner in Willimantic, one in the northwest corner in Winstead, and then one on Zoom. And I'll pass it back to Nick. Next slide, please.
Thank you, Joel. So in our application, we proposed 4 broad initiative buckets, which house the 31 sub-initiatives that Joel mentioned. Our proposals were designed based on a combination of stakeholder feedback, our understanding of the problems, and that constitute barriers for rural residents to seek healthcare, as well as the ever-changing guidance from CMS. And we wanted to highlight several projects here that directly relate to children's behavioral health for you all. Chief among these is a strong push to enhance in-school behavioral health interventions, including projects that will improve training and referral resources for schools, and a program that will increase the availability of in-school behavioral health clinician supports. We also proposed projects, that would enable the state to make direct investments in primary, maternal, behavioral health, and dental care, and support providers in seeking to transition to alternative payment models to ensure that these providers will remain sustainable access points within their respective communities. Notably, this project will improve rural provider capacity, which will ensure continued availability to needed services for youth, and will build upon recent Medicaid rate increases as supported by last year's Medicaid rate study. Several of our proposed projects focus on improving care coordination and managing capacity among rural providers. These measures include access to and features of the state's Health Information Exchange, CONI, to improve screening, discharge, and information sharing capacities. This also includes a proposal that would enable the state to make investments to support dedicated, clinically embedded care coordination functions and navigation services in primary care practices, enabling those providers to coordinate and collaborate more efficiently across social services, behavioral health, and dental care and other clinical providers. Lastly, in this table, we have several proposals that seek to expand the healthcare workforce in rural areas. These projects include incentives to attract various types of licensed and unlicensed professionals to underserved rural areas, career education and training initiatives through UConn's Area Health Education Center, AHEC, the creation of additional rural residency placement options, including for behavioral health residents, and investments to support the implementation of the state's various interstate licensure compacts, including the Psychology Interjurisdictional Compact, also known as PsyPact. We can advance. Thank you. The next two slides list the various individual projects that we proposed under the 4 broader initiative buckets. These buckets were deliberately organized around the 5 strategic goals that CMS had reported they will be prioritizing. And this was really done for 2 reasons. One, to make sure that our rural health transformation proposal was comprehensive and addresses the many different factors that collectively reduce healthcare access for our rural residents. And 2, to make our application more compelling to CMS, in that our initiatives align closely with their priorities to improve the likelihood of us, capturing as much of that second pool of funding as possible to support our rural communities. For time, I won't read every single initiative on the next 2 slides, but I do want to highlight a few that I summarized in the previous one, including under the Population Health Outcomes Initiative bucket, the Access Mental Health Model expansion, particularly the segment that includes expansion for school-based mental health initiatives. And then under the Workforce Initiative, we have the licensed and unlicensed provider incentives to attract a talented workforce to rural areas, residency options, which include behavioral health residencies, as I mentioned, and the interstate licensure compact support. We can advance. Thank you. On this slide, under the Data and Technology Initiative, we have proposed many upgrades to the Connie platform to improve the services that are available on there and enhance access to rural providers of all types. This also includes the creation of a predictive analysis platform to identify areas of unmet healthcare needs in rural areas, and improvements in access to telehealth capabilities both on the consumer and clinician side. This Care Transformation and Stability Initiative bucket also includes a high acuity school-based behavioral health programming initiative that was proposed by SDE. And that really is broken down into 2 parts that I want to explain to you. That includes part 1, evaluating the effectiveness of rural schools' behavioral and mental health systems, and 2, based on those evaluations, recommending appropriate scalable interventions to meet schools' individual unique needs. Interventions may include providing training opportunities for school administrators and staff, technical assistance, establishing partnerships with mental health providers and streamlining referral processes, and enhancing on-site mental health service capacity through a push-in approach where support staff work with students directly within their school settings. One of CMS's core priorities for this grant program was that the funds be used for upfront investments in infrastructure or otherwise be one-time investments that have long-term benefits. It was clear from the beginning that they would not be willing to fund initiatives that lacked that transformation component or that would rely solely on the availability of fundings to sustain the benefits they provide. Therefore, while considering and designing the state's rural health transformation initiatives, we focused largely on those one-time scalable investments to minimize the risk of a funding cliff at the end of the 5-year program. For initiatives that do have some recurring program costs beyond their implementation, the state will examine the efficacy of these programs and consider those that are successful and truly result in healthcare savings for our rural residents for future state investment, which is fairly similar to the process that was employed for programs that were funded with ARPA funds during and following the pandemic. For other programs that include the creation of services, the state will explore opportunities for attaining sustainable funding through a combination of private insurance, Medicaid, and private-public partnerships to ensure that they'll remain available beyond the grant period. And of course, our progress toward meeting these sustainability goals, as well as the goals that we set for ourselves with respect to each initiative, will be monitored on a rolling basis to make sure that we're keeping track with the objectives that we set for ourselves. We also wanted to highlight that the state received broad support from a variety of stakeholders in Connecticut, including not only you all in TCB, but entities such as the Connecticut Hospital Association and the New England Association of Rural Health. Our application, we're pleased to say, was also submitted with bipartisan support from our state legislators, which we anticipate being a significant highlight for our application, as we've heard that this is not something that every state was able to do. And with that, I'll pass it back to Joel to discuss the next steps for our Rural Health Transformation Program.
So we submitted the application very recently, and we have already begun planning for implementation because it will be a very fast process. 5 years sounds like a lot in a vacuum, and to each of us personally, it certainly is. In this case, it will be 5 years that moves very quickly because each year of funding, if the state's approved, will need to be allocated within that budget period, and then the funds will need to be spent by the end of by the end of a 12-month period. For anyone who is familiar with the COVID dollars from ARPA, it's a similar idea, but it's actually even more aggressive time frame because each year has its own individual deadline. So we are working as quickly as we can to start setting things in motion, hoping for good news from the federal government by the end of the year, and then there will be a lot of work, and we will certainly be reaching across all the involved agencies and other stakeholders so that we can make the best difference we can for people living in rural areas. So with that, we're happy to answer any questions. I defer to the chairs and others how much time is available, but we're here for as long as that time slot allows.
Jeannie?
Thank you so much. This is really exciting. Coming from Southeastern Connecticut, thrilled, and the need, we're desperate, desperate. I just have one question about the incentives that you mentioned, licensed and unlicensed. So I'm wondering, would community health workers be incentivized to participate in this, and also navigators with lived experience? Because we find that they're key to doing a lot of the work, especially the outreach piece. You know, and I'm thinking about, we have large immigration community, and people understandably are scared to death to come forward. So I think having community health workers, people with lived experience who are part of the different communities for the immigrant community, and also kids who are homeless. So there are incentives for that, like community health workers, that navigators. Thank you.
Yes, thank you for the question. For our credentialed but unlicensed healthcare workers in the state, we propose salary supplements. So rather than implementing something that would constitute a direct award to incentivize somebody to work in these areas for purposes of loan repayment or paying down a house or just accepting a loan as an appropriate incentive, we wanted to be able to enable providers to be able to bid competitively for staff based on higher wages in rural areas. Thank you.
Alice? Welcome to the world of nonprofits, right? I know you got 7 weeks to write a $1 billion grant. Good work, and I think you did a really great job in terms of outreach and the focus groups and the people that you were talking to. I think the work that's being done here will help inform. You had said that you're going to have some I forget the word you used, implementation or pre-meeting. So just give us a heads up and we're on board. Thank you.
Any other questions? Oh, Chris.
Thank you. And thank you for all the work you've put in with regard to this grant. You mentioned interventions for high acuity students, and I just want to was hoping you could say a little bit more about what's envisioned there and whether that would include intensive interventions for children with behavioral health needs in schools, and sort of how far reaching that might be. Would it allow, districts to hire board certified behavior analysts, for example, and sort of what kinds of things could they do with that?
Thank you so much for the question. Yes, of course. So this model is based on one that SDE recently piloted, but will be exclusively in rural areas. They're hoping to provide this resource to all 41 rural school districts. The high acuity school-based mental health programming refers to the first part of the initiative where the program staff will be conducting these thorough evaluations to assess each school district's behavioral health support services, and identify where there are outstanding needs or where some of the services could be enhanced to meet the needs of their students. So for high acuity students, this would be those with the greatest need in schools. This is where they would employ the push-in approach of bringing clinicians into the schools. I believe that this would be as needed, but I can take that question back as to whether or not they would hire clinical staff to work in the schools. But that would be um, bringing the clinicians in and allowing them to work with the students within their classroom settings and privately on school grounds would be the highest level of acuity for that program.
So when you mentioned that this is already a program that SDE is looking at, I'm curious of all of these programs, which are, and number one, kudos to you all for pulling this off so quickly, to have 250 comments, to have listening sessions, to do all of that in what, about 7 weeks? Yeah, it's a lot. But I was curious, and you may not know right off the top of your head, but of all of the things that are listed here, what percentage would you say are germs of things that are already being done within different areas that you pulled together for this?
That's a great question. I'm not sure of the percent offhand, but I will say that we leaned heavily on evidence-based programs as something that one, CMS would like to see, that the programs that we're putting forward, we're confident will be successful and that we can show that they've been successful. So a large number of these programs do build upon either models that have been successfully piloted in the state, including the school-based interventions, the Access Mental Health Program, the Bridging the Digital Divide is one for the elderly, and Family Bridge, which provides postpartum maternal care and child support. And there are many others that we've based off of models that were implemented successfully elsewhere. So a large number, if not all of the initiatives in here that are programmatic, are based on evidence-supported, measurably successful interventions elsewhere.
I can't imagine why Connecticut wouldn't get this funding. Just kidding.
Okay. Thank you both so very much, and thank you for collaborating with us. And we welcome to have you back for an update, hopefully with very good news. So thank you. All right. We would like to give the floor to our next presenter.
Hi, I'm Wendy Ward, founder of Futures Drive. It is a thrill to be here. I'm honored. I am impressed by all the work so far. So let me focus because I have one, I think, critical piece that I want to introduce to you today, and I'm pretty excited about. So I founded Futures Thrive to modernize mental health screening and monitoring. I got here because I had a child with an undiagnosed mental health condition, and it set me on what has now been a 13-year path to solve the early intervention piece. And I'm just going to qualify one thing. I'm defining it slightly different, right? We've had a lot of conversations about needs when kids start to bubble up and have crisis or serious mental illness or issues. We are taking early intervention to a new level, like we do for everything else, height, weight, hearing, and looking at intervention at the earliest possible moments. So next slide, please. So, I mean, I'll go through this quickly, but just to level set today, you all already know what we're facing. We've talked about it: stigma, workforce shortage, burnout. I looked at some of your materials from previous meetings, inconsistent and fractured data and funding issues. But again, we still need to do the work, which I'm so grateful that you're all doing. But we need to reduce the onset between onset and diagnosis. We need to increase intervention effectiveness. And then the big long list of chronic illness, hospitalization, failure, early pregnancy, all of that, we need to reduce those numbers, and we can do it. Next slide, please. So when I look at the 11-year gap between onset and diagnosis that the CDC reports, I see a child who might be suffering in early elementary school and not get the proper support that they need until high school. And that's just too late, and it's not acceptable in my view. Next slide, please. And coming from having been a family who struggled, this is what it looks like from the family perspective. And again, I think you all know this. A family could send their child to school and the kid's suffering with math, but at the end of the day, he's getting bullied. And a child could go to the doctor and they have endless stomach aches, but at the end of the day, it's stress because something's going on at home. And so by the time we get them to the therapist, we're using tools from the 1980s that really just acknowledge always, sometimes, or never, which if you have kids, I don't know a child that lives in always, sometimes, or never unless they want something from you. And then everyone has it. So again, it's fractured from a family perspective. Next slide, please. So we set out, and again, a lot of this sort of stemmed from my own family's problems, to say, what if we could do this differently? And so what if we can uncover a child's issues in less than 10 minutes? What if we could set a path and reduce disruptions and reduce administrative burden? And what would that look like to intervene early? Next slide, please. Oh, that's all right. Don't worry. So we at Future Strive have a team of people. We worked with kids and parents and healthcare providers in a number of different specialties to create 2 gamified platforms for kids ages 5 to 9 and 9 to 16. A child comes in, they engage with it's not Minecraft, but it's really engaging for them. And the best part about it is it's easily accessible on any tablet. And it does everything that the American Academy of Pediatrics lists out that we're supposed to know about a child's mental health. Next slide, please. So again, the system is what you already know. A child is struggling, they present themselves, a professional, be it a pediatrician, a mental health professional, or a school professional, will implement the survey. And within minutes, you have a comprehensive report. It is a comprehensive report that has all the different buckets that we need to look for. And then your population data begins to build over time. So what's happening in one town in Connecticut may not be happening in another. So your population is what you're looking at. We can triage large populations at the same time, and we can start to standardize a wider range of struggles and monitor in real time. Next slide, please. This is the video. So this is a little sneak peek into what the child would experience. Just image-wise, you can see what we're doing. No, it's okay. They're just heading into YouTube.
A 21st century screening tool, not our latest science. Meet kids where they are. Built in partnership with doctors and experts across multiple health fields. Creating first of their kind mental health baselines.
So you saw a little bit of a scroll of the report, but again, it's a comprehensive report. It aligns with the American Academy of Pediatrics. It aligns with the DSM. While we're just a screening tool, we wanted it to align with all the proper diagnostic if it became that for the child. Next slide, please. So as far as the population information, what I did is I pulled out of a research study we're in the process of doing. I was going to present in January, so I fast forwarded it. So bear with me a little bit. When we look at a population, one of the things we get excited about on our team is all the positive information we ask. So in this particular population, 921 students went through Twain and completed it. And what I wanted to highlight is that the top 5 characteristics that correlated with mitigating anxiety are all possible and all doable at home. So this is a child that identifies with having a parent that listens to them, is patient with others, cheerful, playful, and eats dinner together. And I will say that the method of our questioning is to ask on a scale and then ask a follow-up question. Kids, we have 24 areas in the survey where kids can give us more information, root cause, contextual information, and it's fascinating what they give us, and it's very encouraging. Of the 58 parent characteristics that we ask that they identify what parents they live with have, of all 58 risk and protective, the top 5 were positive, regardless of what was going on with this particular population, which is in a challenged region of the country. They have parents that are happy, listen, patient with others, spend time together, and are cheerful. Next slide, please. So in these particular graphs, and again, bear with me just because I pulled them to highlight the type of work that we can do for you, is we also can look at the challenges. So on this first slide, what you're seeing is there's a pop at the age of 10 where there's heightened sadness, stomach aches, and nervousness. Now, typically, the screening tools that we use today start in like age of 11, 12. This is really important because kids are telling us that they need help before the age of 11 or 12. And then this other one, chronic worry about being discriminated against. If you look here, you can see on the chart that ages 9 and 10 were actually the highest level of worry. Next slide, please. So what do we do within our system? We encourage mental health literacy. We encourage immediate actionable education. And because we ask a lot of positive questions, it's strengths-based, and we can put forward a conversation with a parent that is proactive, and yet also positive. But we've partnered with Dr. Brian Allman out of the Adverse Childhood Experiences Research and Literature, and he's written for us coping skills for stress and healthy behaviors and grief. We ask about grief, very important things that we can immediately engage families with. Next slide, please. And the reality of stigma is that when we enter in at an issue where it's crisis oriented, it's going to be scary. It just is, because we're humans. And if you're talking about a child that's suffering in middle school and high school, you're talking about a child whose consequences are looming in front of them as far as what the rest of their life will be. So we have to start entering into the conversations earlier. And so what we do is we normalize the conversation when I like to say the problems are small-ish. So we get a lot of kids who report that they have a pet death when we ask if you've had someone recently die. Lots of kids report pet death. That's an easy conversation. It's likely their first exchange with loss. And so those are the things that we can do. And in normalizing the conversation, we will address stigma. Next slide, please. Our overall, our overall goal as a company is to introduce this missing link into the work that's being done. There's a tremendous amount of work, and I don't have to tell you because you're all doing it and you're on the forefront of doing it. But we have created a flexible tool, again, strengths-based, it's fast, it's actionable. It is in line with all of the right compliances. Next slide, please. But we still, as we're out in the field doing the work, bump up against problems. The pediatricians that we're working with in Texas are constantly saying, well, what next, right? Because they may not be connected with behavioral health. And so these are opportunities that we can look at as you look at this continuum of care in the state of Connecticut. Schools, again, I'm so excited about the rural health initiatives. I'm actually working on some rural health initiatives in Texas, of all places. But schools are understaffed, and so we need to look at that. Therapists don't get reimbursed for screening. And these are what we hear from the field as we're working with partners. And then families don't know what they don't know until they have to know. Next slide, please. So as we look at the continuum of care, we look at the opportunity to screen. Number one, just helps give us a baseline of where this kid is at. Number two, gives the child a voice for what's going on in their own life. Too often we think we know, and I have 2 teenagers, and trust me, I don't know. So screening at the well child visit, incentivizing that is a good thing. Connecting pediatric care to behavioral health care is also something that's emerging in the US. Screening at school and empowering other workers within the school. One of the things we hear a lot about the school nurse. Can the school nurse do mental health screening? Trust me, the school nurse sees it all, right? Early education programs, I mean, we're already doing it here in Connecticut. Incentivizing these collaborations, I heard a lot about that today. Allowing therapists to bill, allowing therapy centers to bill for screening. It's really important from the work standpoint. And then considering supporting non-diagnostic care. Again, when we look at the problems, if they're small-ish, they're not going to meet a diagnostic code, and then therefore they fall off the map, and maybe they happen and maybe they don't. Next slide, please. So we've talked a lot about this. I'm just going to cut all the way to the end. At the end of the day, we can help the state of Connecticut put together the first of its kind longitudinal data set. We have 96 different risk and protective factors. We have 24 open-ended questions. We can really add value to the data that you're already collecting, and we can do it in a seamless way. And we also can help look at very specific populations, especially with the strength of Connecticut being, 146 different towns? Okay. So, there's going to be a very different existence in all the different locations. Next slide, please. So I get really excited about this topic, as you can probably tell by how fast I went through this presentation. But at the end of the day, prevention reduces stigma. It makes things less scary. I really believe that this work in screening and doing consistent screening over time can actually reduce the burnout. I believe that the positive reduces burnout. When you can look at a child's folder and see not just their struggles, but what's going right in their life, I can't tell you how many kids remark in the survey that they're a good friend, or that they were a good friend in a moment, or that they bring their friends together. There's a lot of positive that we need to start to hear when it relates to mental health. That, again, efficiency increases workflow, reduces crisis. You guys know, because this is what you're working to do, and we believe that early screening is that missing link. And at the end of the day, the new world where kids are thriving looks like all of the things we talked about in the beginning, not reducing, not the need to reduce, but we reduced it. We reduced the timeline between onset and diagnosis. We increased intervention effectiveness. We reduced long-term chronic illness, hospitalizations, school failure, early pregnancy, unstable employment, risky behaviors, not just substance abuse, but all the other things that kids can get their hands into, and ultimately reduce the strain on our healthcare system. I get really excited about it. Thank you for your time.
Questions? Questions? Because I have a lot.
Sure.
Can you talk to us about where you're doing it? What basis you have for the information? I know you said 921 children, but give us a little more of the
Yeah.
scope of where you are and what you're doing.
So we're working, I mean, we're all over the country. We've got some relationships building in California. We've worked with private schools in California. We've worked with a Medicaid provider in Texas. We're working on a rural health project in Texas. We have public schools and charter schools in New York City. So we have a lot of different use cases going on right now. We have a unique relationship with the NYU School of Social Work, where they are trying to have their social workers be work ready when they hit the ground after graduation, not have to spend another year training on what in-school social work looks like. So they've provided these tools to get ahead. We're in mental health providers. It is meant to run 3 to 4 times a year on a child. It is screening. So in a therapy use case, what we've found is that therapists could run into a stalemate with their client and then run the screener again, and then they find out something that's happening in the life of that child that maybe the child didn't know was appropriate, or would change their mindset. And then again, at the well child visit from a pediatric standpoint. Does that answer your question?
Yes, thanks. And then also, what is the reaction of parents? Because of course you probably have to get parents to sign off, give permission for the child to be screened.
So it totally depends the state, and we track mental health friendly states. And we work with, yes, Texas is a perfect example of where there has to be consent. What our universal feedback from parents is, wow, I really had no idea what my child was thinking. It's really powerful information. I mean, at the end of the day, to give the child a voice in their own life, we could think that it's because they're failing math, and we could think that it's because parents are getting a divorce. But at the end of the day, it's something that we have no idea about. So that tends to be the biggest feedback from parents. I had no idea.
Sorry to be asking all the questions here.
Yeah.
Longitudinally, do you have, I don't know how long the tool's been being used. Do you have any sort of scope or information on
We're just
a child who is screened and then?
Great question. We are a year in the market, so we don't have that information yet. But we have a litany of data, which we know, again, 96 different risk and protective factors. We've just started to take a deep dive into what correlates to anxiety and depression, what doesn't. I mean, some of it is very much what we already know exists, and some of it is new and enlightening. When we did our research study partnered with the National Science Foundation, we compared to the pediatric symptom checklist. And we were an 87% match to what they ask about. But why that's a little bit different is because the differing point was we asked so much more. So again, grief questions, we get lots of kids report that they have sleep issues. I mean, it's really fascinating when you look at what they're willing to report on a game, but would never tell you face to face.
Howard?
Hi, thank you. So I have a question. Can you give us like a demographic profile of the kinds of kids that are utilizing this tool and benefiting? Because not all kids are the same. And
course.
and certainly the developmental needs of kids change as they get older. And does it looks like it's an app or something?
Yeah, it's a software. Yeah. It's an app.
Right. And I'm sure it's targeting a certain age group, or
Yeah.
not.
Yes, so we have a younger version. The younger version targets ages 5 to 8. They don't need to read. Where you saw those helper animals, they pick one of those animals and the animal talks to them and does the interview. Then we have ages 9 to 16, and they do a little bit of typing and clicking. That was just a business decision. But actually the older ones type the most. So the demographic, we're general use across any age group is, again, meant to be a general use screener. So we've got a very wealthy private school in California. We've got the city of Las Vegas and everything in between.
Do you have it in other languages?
We're getting there. We have translated it into Spanish and we're in the middle of developing it. I would imagine the middle of next year, it'll be, we had all of our images looked at, like we've done the base work. We just have to develop it and put it into the system.
Yes.
Just to follow up, it's been translated into Spanish. How are you going to validate it for Latino communities?
Oh, we're going to have to do that work. I mean, absolutely. We're looking for partners to do that work.
Right, it's one thing to translate.
Yeah.
Valid.
So just a little bit about me. I actually majored in Spanish in college, so I know enough to know that we could do it really badly. And if you already know, I said that I got here by way of a child who suffered, and so we're not going to do it badly. So we're taking our time and doing it. We are looking for partners to do that. But absolutely, we're going to make sure that it's right.
And another question, this is not something that is marketed to children. You can't download this app onto their phone.
Absolutely not.
This is through professionals who are utilizing the app.
Yeah, so that's actually a really good question. When we sat down to do this, what I started with was a laundry list of ways of my own experience and where the gaps were, and said, how many of these gaps can we fill? And when I said that parents don't know what they don't know, I really meant it. We were parents with means, and we thought we knew what we were dealing with when we were not. So we made the decision to work through licensures. So social workers, therapists, pediatricians, anyone who has the ability to follow up to some capacity and to have the conversation with a parent that can protect the child.
Thank you.
Thank you so much. Thank you. We'll
Thank
be in
you.
touch.
I
Okay.
appreciate your time.
All right. And all right, I believe that concludes our meeting. Our next meeting does come up fairly shortly. It is on December 3rd. And as Emily had mentioned earlier, we have already been working for a few months now with several of our stakeholder partners in regards to taking a deeper dive into the crisis continuum part of the full continuum of services. And so the December meeting is going to be a data spotlight on that. And I look forward to working with everybody who's on that panel. You'll have a very comprehensive panel discussion. Other than that, it's December 3rd. And happy Thanksgiving, everybody. Thank you for those that celebrate. Thank you.